I want to thank Dr. Mark Meissner and Dr. Ed Boyle for agreeing to do this podcast on a recent series of articles that they put out for a virtual special issue for phobology and also for the JVS VNL. This series of articles looks at the anterior saphenous vein and really looks at diagnosis, treatment, and a couple of other tradition issues also. So Dr. Meissner works up at the University of Washington. He's a professor there. He was the president for the American Venous Forum and also is the president for the Intersocietal Accreditation Commission for Vascular Intervention. Dr. Ed Boyle is the founder and CEO and a practicing physician for Inovia Vein Specialty Centers and has also had quite a number of devices that he's developed with being the founder and also the developer for these device companies, which has been really quite exciting. So thank you to both of you.
Thanks for the invitation.
Thank you for having us.
So how did you get interested in this particular topic? Dr. Meissner?
Well, I'll say this project was really driven mostly by Ed, who really noticed there was a disconnect between the way we talk about the anterior saphenous vein, or what was formerly the anterior accessory saphenous vein, and what its true anatomy is. And if you go back to 2001, which was the last anatomic update by the International Union of Phlebology and some associated societies, and it was a very clear anatomic study in which they defined truncal veins as arising within the fascial compartment. And in that manuscript, they distinguished the great saphenous vein and the small saphenous vein, but left the anterior accessory saphenous vein as not being a truncal vein. And it sort of contradicts their own definition of what is a truncal vein and what is not a truncal vein. In particular, truncal veins are largely contained in their own saphenous compartment, which the anterior saphenous vein is, yet it was excluded from being a truncal vein. So there was an anatomic anomaly there that Ed recognized, and I think many of us recognized in the field, that not only was anatomically incorrect, but also has led to a number of problems with treatment and ultimately with reimbursement for it, as this being an accessory saphenous vein rather than a true truncal vein. And that was kind of the impetus of this, that Ed drove this whole project to really get rid of the accessory part of it, because by true anatomic definitions, it's contained in a membranous fascial plane and should be regarded as a truncal vein and treated as a truncal vein, and the treatments are similar to other truncal veins.
No, I think that's great, Mark, and it's too generous to say I drove it. I was just lucky to be part of the group. We had a wonderful group of folks working from AVLS, AVF, UIP, Dr. Caggiati from Rome, who's a very noted anatomist and could really help us think through the anatomy and the history behind the nomenclature, which I thought was really fascinating. But from my perspective and my journey in doing a lot of superficial vein work over the years, like Mark's saying, we all feel comfortable that the greater saphenous vein is the truncal vein and it needs an ablation technology such as thermal or non-thermal to try to get that long-term treatment that's kind of minimize the amount of time or maybe the need to come back later. And same with the small saphenous. But on the anterior, there was this thought in many people's mind, is this just a branch? And if it's a branch, does that require a different type of treatment like phlebectomy or just kind of physician compounded foam, which we knew from more and more papers coming out just wasn't as good as an ablation in that area. So I think this kind of collective appreciation that, hey, we need to look at this and got to take the hood up here and see what's going on, get a consensus going between folks from different societies and different backgrounds. And it took a little bit of time. We thought it might be one paper when we were done, but it turned out to be 4. And the first was just a position paper to kind of lay out why, which Mark led. The second was mostly focused on anatomy, what Dr. Caggiati authored, with amazing illustrations, I think, that really helped understand, where's it coming from, where's it going, what are the variations, which he did a fantastic job and was really great to work with. The third, we had a medical student, Rachel Dragaston, who helped lead a systemic review of the literature. So we could try to capture as much of the prior publications on the subject, which you can see going up the last couple of years, as well as a payer analysis. We used the American Venous Forum Policy Navigator, which has, it's like a database that has all of the payers in the United States. And Rachel went through each one and was able to pull who covers it, who doesn't, why. And then the final paper that I led was about some of the clinical scenarios and some of the pearls and tips and tricks for treating these patients that might be slightly unique compared to, for example, the Great Saphenous Vein. So that's how it all panned out. When we were done, what we thought was going to be one paper was 4. And then we were very fortunate that the interest level was high enough to get the endorsements from the societies, and also simultaneously published in both journals, both Phlebology and the Journal of Vascular Surgery, VL as well. So it was a big project, but it turned out to, I think, help add a little bit to our understanding on the subject.
So, Dr. Boyle, would you be able to focus on some of the treatment options that are available with some of the nuances in terms of treating?
Yeah, absolutely. First of all, the treatment modalities available are the same, right? So if you take forget our old techniques of high ligation and stripping for a second and say, you've got thermal ablation, you've got cyanoacrylate, and you've got endoscopic microfoam for the most part here in the United States right now, and MOCA. So those are your treatments. The question, sometimes they're short, and it's going to be hard to get a guide wire in. Sometimes there's a question whether this might be higher in patients with obesity or not. I've seen some conflict in the literature on this, but in my practice, I feel like we see it a lot in people that are more obese, and so you're trying to work really high in the thigh and try to overcome that curve down toward the groin. So there's some technical considerations. Are you going to be able to readily get access and lay down a catheter and feel good about your tumescent anesthesia? So having some non-tumescent options for that is also, I think, helpful. Mark, you want to touch on the whole concept of the branch varicosities, whether they need to be treated or not? Because I thought that was really interesting as well.
Well, back to take just a step back to the systematic review part of things. It's very clear from the literature that number one, for the most part, VCSS scores and SEEP scores are very similar between anterior saphenous reflux and symptomatic saphenous reflux, and both get a similar benefit from ablation to it, that the results are very similar. Yet another clinical reason why it should be regarded as a truncal vein. In the systematic review, it's about 20% of patients will have either isolated anterior saphenous reflux or anterior plus great saphenous reflux. And I think the numbers are about 12 or 13% will have isolated anterior saphenous reflux. 7 or 8% will have anterior plus great saphenous reflux. So that's the benefit of the manuscript with the systematic review. Really shows that both the severity of disease from the patient standpoint and the outcomes of treatment are very similar between the two, and it's about 20% of patients with that. Then the third paper, or the second paper, depending on how you look at it, is Alberto Caggiotti's anatomy paper. And if you're going to read one of the 4 papers, that is the one I would read. He did a really nice ultrasound study of 60 normal patients, 60 patients with anterior thigh varicosities, looking at the origin, the termination, and the course of the anterior saphenous vein. And I think in treatment, it's very important to understand the anatomy that Alberto's outlined in that. First of all, about 10% of patients, it'll be with varicosities, it'll just be present in the proximal third of the thigh. About 40% of patients will extend to the mid-thigh. So that 40% will have a longer segment that's available for whatever ablation technology you use. The second thing that's very valuable in that paper is what is the origin of the anterior saphenous vein? And he describes three patterns of origin. The one that we see fairly often is the one where the anterior saphenous vein joins the great saphenous vein. He describes that as the embryonic pattern of the anterior saphenous vein. Some people might call it a duplicated great saphenous vein, but it's really not, because the anterior saphenous vein, as we know, runs just anterior to the superficial femoral artery and the femoral vein. So it's a little bit different course. But that's one pattern. The second pattern is to give rise to branch varicosities in the mid-thigh, and the third is to communicate with the anterior thigh circumflex vein, which generally swings laterally in the thigh and goes down. So in treating them, I think it's very, or even in diagnosing this with ultrasound, it's important to understand those patterns of origin from that, and exactly, you know, where you can expect the anterior saphenous vein to terminate. I think, and maybe I'll let you expound on the branches, because my personal opinion on you know, treating tributaries of the anterior saphenous vein is, unlike great saphenous tributaries, they don't resolve as often. Is my
I mean, I think that was the theme, and I found that as well. You know, there's this sort of equipoise, like whether or not you treat the branch tributaries at the same time as you do your ablation, or whether you let them heal up and see what needs to be done. We've debated that a lot over the years, and people have their different opinions on that. But the data from some of the papers that were published on this was that when you are working, especially in that lateral thigh, sometimes you treat the truncal vein, the anterior saphenous vein, and those branches are not going away because there can be some overlap with the circumflex veins and some things like that. So I tend to count on the fact that I'm going to need to get those treated. And there was actually some really nice, I think the paper that came out of the CVR group that showed that they had an initial drop in their VCSS scores that was pretty consistent. But then if you didn't treat those branch veins, it came back up pretty quick. So,
right.
and there was other papers like that. So it kind of said, hey, you know, don't let these people get too far away. You better make sure if they want to make their symptoms go away, you're probably going to need to take care of that. And so I tend to try to get that done earlier rather than saying, hey, come back and tell me if that's still a problem later. The other piece on that I thought was really interesting is there's another pattern where it's a hypoplastic great saphenous vein in the upper thigh, and then it blows out laterally into the anterior saphenous and then comes back in around the knee. But in that case, you're going to need to ablate that anterior saphenous vein, but you're probably going to need to ablate some of that vein that's kind of like from the lower thigh to the upper calf or the mid calf. And that's where this reimbursement piece becomes challenging, because if you look at it, you say, I want to just take care of this person, I can get it all done. And they're telling you, you got to treat the great sap first, and then you got to wait, then you got to come back. And now it's just turned into a sort of a kind of a time and money suck for the patient and the payers and everybody. And we're trying to educate those folks that, you know, if you let us do our job, we might be able to do it for, you know, for quicker and for better outcomes long term than if we're letting those kind of philosophies come in.
Very great. Any other points that you want to point out for some of the for the series of papers, guys?
I think the big picture is, like Mark was saying, that 1 out of 5 patients who show up in our clinics who've never had vein procedures before are going to have an anterior saph vein. And if you look at Dr. Kajiati's paper, you can look at all the different variations. And the other piece where I think this is really interesting is in recurrence. Okay, folks that have had prior treatment, that number is going up, right? Because when we first started doing ablation, the most common cause of recurrence was recanalization. Right. And I suspect, what? I'm sorry?
Yeah. And in the days of stripping, neovascularization.
Right. So those forms of recurrence are going down. You know, we still see those folks or whatever. But what I see all the time now is somebody I saw 5 years ago. I treated their great saphenous vein. They did not have anterior saphenous vein issue at the time. Now they're back with the anterior saphenous vein. Right. And there is a very interesting clinical trial in Europe right now looking at whether or not you should prophylactically treat the anterior saphenous vein that's normal to reduce recurrence. And I know some of that data is starting to come out, but it'll be interesting to look at. I'm not promoting that we should or shouldn't, but the concept was, hey, you're there. I think one of the challenges we saw from Dr. Caggiotti's study of normal patients is that vein is going to be tiny, and in a normal vein is going to be tiny, and I don't know if it's going to impact the natural history. We'll see.
But
And
also,
probably-
go ahead, Mark.
The only other thing I would add from the epidemiology part of it, of the paper, was it is clear from the literature is, tend to present with similar clinical severity, have a similar outcome, with the exception of the incidence of superficial venous thrombosis tends to be substantially higher in the anterior saphenous vein tributaries than it is in the great saphenous tributaries. And I think that's the other part epidemiologically that's important about that this, in fact, is an important truncal vein rather than just a tributary.
But also you highlight the fact that the anatomy is crucial in as much that the anterior saphenous vein crosses over the proximal superficial femoral artery. And if you are not careful with the anatomy, the tumescent, and where you use your thermal technology, you could end up with a fistula, which, as you appropriately so caution against and highlight the prior reported cases. So I think the anatomy, going back to what you were saying, is crucial to understanding. It's just one of the reasons why I think this paper is so important. It really brings together multiple components that really do make a big difference in terms of diagnosis and treatments for these patients, and you've summarized them beautifully. So thank you so much.
Yeah, thank you for the
Thank
invitation.
you.